for this presentation's discussion is radiographic evaluation of wrist and wrist trauma. So while assessing the wrist, the standard radiographic views which are obtained are the posterior-anterior view and the lateral view. Usually these two views are sufficient. However, sometimes an oblique view can be taken for better assessment. Some additional special views which are used in special clinical scenarios are the ulnar deviation view or the scaphoid views, which are helpful in detecting occult scaphoid fractures. Other such views are the carpal tunnel and carpal bridge views, which are used for assessing the carpal bones better. In carpal tunnel view, the palmar soft tissues and the palmar aspect of the carpal bones is assessed better, whereas in the carpal bridge view, the dorsal soft tissues and the dorsal carpal aspect of the carpal bones is assessed better. So coming to positioning and anatomy of in case of a posterior-anterior view, the patient is made to sit next to the table with the shoulder in abduction by 90 degrees, the elbow inflection by 90 degrees, and the forearm pronated with the hand and the wrist lying flat on the surface. So in the second image, we can see the PA view, which is very clear, and we can see this to be the distal end of the radius, the distal ulna, the carpal bones, and the metacarpal bases. Now, the carpal bones can be remembered by various mnemonics. One such common mnemonic is "She looks too pretty, try to catch her." So this is the scaphoid bone. This is the lunate bone. This is the triquitum. Overlying this is the pisiform. Then there is trapezium, trapezoid, capitate, which is the largest carpal bone, the hamate bone, and then overlying the projection that we can see is the hook of hamate, where fractures are quite common, and finally we can see the metacarpal bases. Now, in addition to the carpal bones, the joints forming the wrists also have to be assessed on a PA view. And here on this radiograph, annotated image, we can see the distal end of the radius and the distal end of the ulna, and the joint between them is the distal radioulnar joint. Then the radiocarpal joints, which is formed between the radius and the scaphoid and the lunate bone. Please note that the ulna does not form a joint with the carpals because of the presence of a triangular fibrocartilage complex, which is not visualized on radiographs, but because of this complex, the ulna does not form any joint with the carpal bones. And then the next set of joints which we assess is the intercarpal joints formed between various carpal bones, and then the carpometacarpal joints which are formed between the distal carpal row and the metacarpal bases. Now, in addition to the joints, we also assess for the carpal arcs. So on a PA view, there are 3 arcs formed by the carpal bones, which are parallel to each other. And any disruption of these arcs would give us a clue towards carpal subluxation or dislocation, and these should be assessed. So the first arc is formed by the proximal surfaces of the scaphoid, lunate, and triquitum carpal bones. The distal the second arc is formed by the distal surfaces of these bones, and the third arc is formed by the capitate and the hamate bones. Another concept which we assess on a PA view is the concept of ulnar variance. Now, the ulnar variance can either be neutral, it can be positive or negative. By ulnar variance, what we understand is that the articular surface of the radius and the ulna, if it's at the same level, then we call it a neutral ulnar variance, as seen on this radiograph. However, if the ulna advances forward, that is more distally, then it's called positive ulnar variance, whereas if in any case the ulna is more proximal, and then we call it negative ulnar variance. So on this image, on this B image, we can see that the articular surface of the ulna is more proximal as compared to the radial articular surface. Hence, there is negative ulnar variance in this case. Whereas in image C, we can see that the ulna is advanced more distally. So this is a case of positive ulnar variance. One clinical implication of positive ulnar variance is ulno-lunate abutment or impaction, wherein the positive ulnar variance causes impaction of the ulna with the lunate and sometimes the triquetrum. And because of this impaction, we can see some cystic lucencies along the articular surfaces of the ulna and the lunate bone. And this results in pain. And this spectrum of finding is known as ulno-lunate abutment or impaction, which is associated with positive ulnar variance. Coming on to the lateral view, in the lateral view, the patient's forearm is in a semi-pronated position lying perpendicular to the plate. And lateral view is basically used to assess the alignment of the third metacarpal, the capitate, the lunate, and the radius. In a true lateral projection, the third metacarpal, the capitate, the dorsal surface of the capitate, the lunate, and the distal end of radius are all along the same line. Also, certain hidden fractures of the triquetrum, this shadow which is formed here, this is the triquetrum, are best assessed on lateral radiograph. So on a lateral radiograph, this, if you can see, is the distal, the shadow of the distal radius. Then this moon-shaped carpal bone is the lunate. Then this is the scaphoid bone. This is the capitate. And here is the third metacarpal base. So coming on to ulnar deviation view. In ulnar deviation view, the hand is rotated by approximately 45 degrees towards the ulna. And this, in this position, the scaphoid is viewed in full profile. So any hidden fractures of the scaphoid can be assessed best on ulnar deviation views. Coming to some distal radial fractures. Now, there are certain types of distal radial fractures, such as the Colles fracture, the Smith fractures, the Barton fractures, or the Schoffer's fracture. And in Colles fracture, basically, there is fracture of the distal radius with dorsal tilt of the distal fracture fragment. So on this radiograph, on the PA view, we can see a lucency, which is probably reaching up to the articular surface. And when we see the lateral radiograph, we can see that there is dorsal tilt of this fracture fragment here. So this is a Colles fracture. When the tilt is ventral, as seen in this radiograph, then it's a Smith's fracture. So on this PA view, you can see that there is fracture, there are lucencies, there is cortical discontinuity, and on the lateral film, we can see volar tilt of the distal fracture fragment. Coming to Hutchinson's fractures or Schoffer's fracture, these fractures are basically fractures of the radial styloid process, and these are commonly seen in drivers when they're starting the engines and then they turn it off, and if there is sudden jerk of movement, then it leads to Schoffer's fracture. Now on this radiograph, if you see on the PA view, it looks quite normal. There doesn't appear to be any fracture here, whereas now when an oblique view is taken, a fracture of the scaphoid can be clearly seen. So there are two common complications of untreated scaphoid fractures. One such complication is avascular necrosis of the scaphoid, where you can see that there is extensive sclerosis here at the site of fracture. And then another common complication is nonunion, where the poles of the fractures do not unite. Coming to Kienböck's disease, Kienböck's disease is avascular necrosis of the lunate bone, and it is commonly associated with a negative ulnar variance. The reasons for which are not quite sure, but on this radiograph, you can see that there is some sclerosis along the lunate bone. And when you see the lateral radiograph, there appears to be volume loss and sclerosis of the lunate bone. And now if we see the second set of images over here, we can see that there is subtle sclerosis on the lunate bone. And here on the lateral projection, you can see this fracture line here and this separated fracture fragment in the coronal plane. So Kienböck's disease is basically avascular necrosis of the lunate, in which we'll see fragmentation, sclerosis, or volume loss of the lunate bone. In this radiograph, we can see fracture of the hook of Hammett, and this is quite a common fracture which is assessed on radiographs. Then on this lateral radiograph, we can see a separated bone fragment over here on the dorsal aspect. And as I had mentioned earlier, this is a triquetrum fracture, which is assessed on lateral radiographs. And coming to scapholunate ligament tears, now this is a spectrum of findings which we see in case of scapholunate ligament tear or laxity. And here, if you see this radiograph, this is the scaphoid bone and the lunate bone, and there is widening of the joint space between these two bones. So this is also known as the Terry Thomas sign or the David Letterman sign, depending on what part of the world you are. But this basically refers this joint space widening has been compared to the gap in the teeth between these two famous between the two teeth of these famous personalities. So in case of scapholunate ligament laxity or widening, the initial thing which we see on the radiograph is scapholunate joint space widening. Also, because there can be foreshortening of the scaphoid bone. If you see this radiograph, the scaphoid bone appears foreshortened. This is because of rotatory subluxation of the scaphoid bone, which makes it foreshortened on a PA radiograph. And then if you can see, there is a ring-shaped projection over here, which is because of the rotation of the scaphoid, and because of this rotation, when seen end on, it resembles like a signet ring. Hence, this sign is known as a signet ring sign. Now, sometimes if there is suspicion and if the scapholunate joint space widening is not very clear, then a clenched fist, a special view known as the clenched fist view, can be done. And this is how the patient's hand is positioned for the view. And because of the contracture of the flexor tendons and the musculature here, there will be widening of the scapholunate joint space. And for better assessment, the contralateral wrist can also be examined. The clenched fist view of that can also be taken and it can be compared. The next spectrum of findings in scapholunate joint scapholunate ligament tear is DISI, which is known as dorsal intercalated segmental instability. Now, because of the tear of the scapholunate ligament, the lunate bone undergoes dorsal subluxation. So here, if you see, this is the lunate, and it is seen to be subluxated dorsally. This is the moon-shaped lunate, and the face of this lunate lies on the dorsal aspect. So this is DISI. So this is a spectrum which is seen with scapholunate ligament tear. The next step in the spectrum, when a scapholunate ligament tear occurs, there's a continued predictable pathological spectrum of findings which is seen. And the next step, the next finding is slack wrist or scapholunate advanced collapse. In this, there is proximal migration of the capitate bone. Here on this radiograph, you can see the widening of the scapholunate joint space. There's proximal, the capitate has migrated proximally. Now, in this second radiograph, again, we can see joint space widening, and we can see proximal migration of the capitate in between this joint space. Also, we can see narrowing of the joint space between the capitate and the lunate, and some sclerosis along these articular surfaces. Sclerosis and osteoarthritic changes are also seen with at the radiocarpal joint level. So when left untreated, scapholunate ligament laxity or tear will lead to a continued progressive pathological spectrum of findings, which includes the initial presentation is scapholunate joint space widening, or the Terry Thomas sign, or the David Letterman sign. Next, there'll be dorsal subluxation of the lunate bone, which is DISI. Then there can be scaphoid subluxation, which causes the scaphoid to appear foreshortened on the PA view, and then the signet ring appearance, which I described earlier. And the next spectrum is proximal migration of the capitate bone, uh, resulting in narrowing of the joint space between the capitate and the lunate bone, and the capitate migrates into the joint space between the scaphoid and the lunate, and then advanced degenerative changes in the form of sclerosis, causing slack wrist. So coming to VISI, VISI is nothing but volar intercalated segmental instability. In VISI, the lunate, if you see, this is the lunate bone, the moon-shaped lunate bone, and it appears to be facing volarly or on the palmar aspect. So VISI is generally associated with tears of the lunotriquetral ligament. Now coming to perilunate and lunate dislocation, in a normal lateral view, as I described earlier, the third metacarpal, the capitate, the dorsal surface of the capitate, the lunate, and the distal radius are all along the same line. And when this collinearity is disturbed, then there can be a spectrum of findings. So if when in case of a perilunate dislocation, the collinearity between the lunate and the distal radius is maintained. They are along the same line, but there is dorsal subluxation of the capitate and the third metacarpal. So in perilunate dislocation, the lunate is in its place, but the carpal, third metacarpal, and the capitate have migrated dorsally. Now, in case of lunate dislocation, it is the lunate bone which undergoes dislocation with respect to the distal radius, and the third metacarpal, the capitate, and the lunate all lie along the same plane. So here in this case, we can see, and more commonly, we see volar subluxation of the lunate bone. Whereas in mid-carpal dislocations, what we see is that the lunate undergoes volar subluxation, and the capitate and the third metacarpal undergo dorsal subluxation. So perilunate and lunate dislocations are assessed based on lateral views, where any disruption in the collinearity between the third metacarpal, the capitate, the lunate, and the distal radius should make us suspicious for any of these type of dislocations. Lastly, coming to distal radioulnar joint subluxation. Now, the distal radioulnar joint subluxations occur when patient falls on outstretched hand, or it can occur when there is direct trauma. And it is generally a clinical diagnosis. The patient will come to the clinician with inability to supinate or pronate the forearm, and it is best assessed on lateral radiographs, where if you see here, for example, on this radiograph, the ulna appears to be migrated dorsally. It is subluxed dorsally. This is the dorsal aspect, this is the ventral aspect, so the ulna is migrated dorsally. On a PA view, we can appreciate the widening. This is another patient. On a PA view, we can appreciate widening of the distal radioulnar joint. And the ulna, if you see, this is the ulnar styloid process, and the ulnar styloid process, it appears more central. So there is some rotation which has happened, because of which this ulnar styloid process appears much more central, and there is increased joint space between the distal radius and ulna. So now finally, the reporting template of a radiograph of wrist, we should first, after mentioning the clinical details, the name, age, date, etc., we mention what view has been taken. Then the first point which we comment on is bone density, whether it's normal or if there's osteopenia. Then ulnar variance, if it's positive ulnar variance, negative ulnar variance, or neutral ulnar variance. Then we should comment on the joint spaces, which are the distal radioulnar, the radiocarpal, intercarpal, and carpometacarpal joints. We should comment whether they are aligned properly, whether their articular surfaces are normal or sclerosed, whether there are any osteophytes, any degenerative changes. Then bony cortices of the bones in forming the wrist joint should be assessed, whether they are intact or not. And lastly, the soft tissue is commented upon. So In this presentation, we discussed the basic views, which is the posterior-anterior view and the lateral view. And we also discussed some special views, such as the ulnar deviation view, the scaphoid view, the carpal tunnel, and the carpal bridge views. Then we assessed some common fractures of the distal radius and the carpal bones, such as the hook of Hammett fracture, the triquetrum fracture, the scaphoid fractures, and then Kienböck's disease. We also discussed the scapholunate ligament laxity or tear, which leads to a predictable pathological spectrum of findings. The initial findings being scapholunate joint space widening on a PA view, then scaphoid subluxation, signet ring sign, then DISI, and then the advanced degenerative uh, findings because of proximal migration of the capitate. Then we commented upon VISI, which is because of tear of volar, which is because of tear of lunotriquetal ligament, where the lunate, it tilts volarly. We mentioned the various lunate and perilunate dislocation and how collinearity between the third metacarpal, the lunate, the capitate, and the distal radius should be intact. And we discussed about dorsal radioulnar joint subluxation, which is distal radioulnar joint subluxation, which is more common, in which dorsal subluxation of the ulna is more common, and it is best assessed on on lateral views. So, thank you.